Thank you. Thank you very much. And thank you, everybody, for having me. Um, Documentation is something I do feel quite passionate about. And my whole career, I've been lambasted for writing too much in notes. Um, I'm not sure you can ever write too much, and hopefully the reasons for that will become clear as we go through that. I've entitled this Negotiating the Minefield because it is a minefield. There's no kind of one size fits all anymore, despite what you're taught in universities. So to begin then, it is a bit of a whistle stop tour because I'm very aware that I have got a limited amount of time and I could talk for England, believe me, I could. What governs us? And you'll all be very familiar with this. I mean, data protection, obviously, we have to adhere to for us as professionals. And the things we're probably most familiar with is the code and perhaps less so for our older midges, the standards for proficiency for registered midwives, because they came in 2019 and kind of, if you've never really looked at them, definitely have a look at them because they are an eye opener of the standards that we are expected to achieve now. It's not just one or two, there is loads in there. And less commonly, but we don't always think of the International Confederation of Midwives, but actually they do to some extent govern us as well. A lot of what they, certainly I'm trying to think of the word, the definition of a midwife comes from the ICM rather than anywhere else. So looking briefly, and I'm not going to read all this out to you because you can read, I'm sure. But point 7 says we need to communicate clearly. And that in itself often has problems, not just for verbal communication, because a lot of people now, we're in a very, very multicultural society, very multicultural. And certainly the area within where I work, I think there's something like 90 different languages spoken. So interpreting services are used frequently, and I suspect I should be using some tomorrow because I've got a booking clinic. And that in itself makes a problem for documentation and also communication because however good the interpreter, unless they are a midwife, you're never quite sure that they're actually interpreting what you are interpreting, asking them to interpret. And equally, you're not sure of that person's understanding. And part of this, if you look at 7.4, check people's understanding from time to time. And how easy is that to do when you have a non-English speaking client? It is very problematic. My personal practice, and I know it uses quite a bit of paper up, is I try and use Google Translate to translate information so I can give, as well as the interpreter, I'm giving the couple a paper copy of the information as well, just so that I can be sure, particularly around things like screening tests, blood tests. These are things that we are asking for informed consent. And if you are not sure that they actually understand what you're asking, how can you be sure that they are giving informed consent and not just saying yes? So it is very important that we really use that range of verbal and non-verbal methods to actually really get to grips with, do people understand what it is we're trying to ask of them? Keep clear and accurate records. This, I think, is extraordinarily problematic in these days. The NMC say that we, and it'll come to it, that our records should be contemporaneous. That means written as close to the event as possible. Now, I'm sure many of you are the same as me, that you're no sooner finished a birth and you're barely got your records kind of in some sort of shape, and you're being asked to take another lady. So sometimes it's quite, there's quite a period of time elapsing before you're actually documenting the care, perhaps for the first person you've looked after. Now, if you've had someone come in, they're in advanced labour, you haven't even had chance to get things open, you're scribbling things on a piece of paper, what you may not realise is that piece of paper is your contemporaneous record, not what you transcribe into your notes, but that actual physical piece of paper is your contemporaneous records. And as such, that's the piece of paper that should be scanned into the notes if it's electronic, kept in the notes if it's paper, because that is your contemporaneous record. And it's very easy when you're tired and you've been asked to do a lot of things to actually mistranscribe things. And if you have got rid of that piece of paper, your contemporaneous note has gone. There's no way of going back on that. Okay, we do need to, obviously on this, it does say about storage, not making things up. And you might think, surely nobody does that. But I can tell you, when we had supervision and I was a supervisor, I actually had to take a midwife to the NMC for falsification of maternal observations. Now, I don't need to tell you that potentially that could have been catastrophic to kind of make observations up. Fortunately, there was no poor outcome and it was purely by chance that it came to light when the mother complained. So, although I'm sure most of you would look at that and think, surely nobody doesn't write things down accurately. Surely nobody falsifies records. Sadly, people do. And I often think that maybe some of that is down to the pressures that everybody is under these days. So keep our records securely. This is even more tricky, I think, now when we are electronic. Most people, I think most people I've come across now do have sort of mostly electronic notes in some way, shape or form. Women have access to those notes, but other people might have access to those notes if you're not careful, if you don't, if you leave computers open at a desk with people's notes on. Remember that, again, it's very easy to do. You're halfway through writing something, the phone rings, you've got to send, give a message to the midwife in charge, your screen's still open, you've left your desk for a moment. That information about that person is actually on display to whoever happens to pass that desk. So you do need to be mindful about shutting locking your screen if you're going to be away from it. 6.4, I always think, is an interesting one about clearly documenting the woman's understanding, input and decisions about her care. Now, I don't know about you, but I very rarely actually see anything written in anybody's notes about her understanding. I see lots of things about what we've discussed, but not necessarily about what her opinions are on it and what her decisions are about her care. And we have to accept, and this is in the code as well, that our job is to give evidence-based information so that women can make an informed choice, or birthing people can make an informed choice. If they are quite within their rights to reject our information, what we give them, and reject our advice, they don't have to say yes. And I'm sure all of you will agree with me that when women do this, we're very good at browbeating them into submission a lot of the time, into coming round to what our way of thinking, because that's what we need them to do. We need them to comply with the blood tests or the scans or the vaginal examinations, or without really thinking, actually, is this evidence-based what we're asking of these women, or is it just actually what we need to get through the day? We just need to get, vaginal examinations is one of my bugbears because it is not a particularly useful, well, it's a useful tool, but not in isolation. And we are very, I think it was Rachel Reed that coined the term cervix-centric. So we are, as a nation, not just as professionals, very focused on the cervix and how many centimeters it is. Even the women are very, very much like that. But it's a very small part in a big picture. And if we're not careful, we're losing our midwifery skills about how to actually diagnose labour without poking women around. And when you get a woman who actually says, no, thank you very much, I don't want to have vaginal examinations, the eyebrows that raise are unbelievable. And I've had midwives in charge saying to me, well, what is she is she doing? Is she doing? In fact, only this week had said poor midwife saying to me, well, what's she doing? And I said, she's in labour. Yes, but how many centimetres is she? I said, I have no idea. I haven't examined her. She doesn't wish to be examined. She is labouring. And sure enough, within about the space of 5 minutes, she birthed. So, and was thrilled with her care. It was her third baby, and she was totally thrilled with everything, that she'd been given the option to make choices about whether she had or didn't have certain things, albeit that was all happening quite quickly. And then our ICM says very much the same sort of thing about complying with local regulations and the law in our country. So for us, this would be data protection and ethical codes and NMC codes. So why is it important? Well, for us, it's a legal and professional requirement. And you might think, well, yes, it is a legal crime. And certainly in the days when I trained, it was pretty much drummed into you. If it's not written down, it didn't happen. And to some extent, that is true. And what I would like to sort of really stress is your documentation is really helpful to the woman. If in the unfortunate event that something doesn't go quite according to plan, unfortunately in this country, these families have no other recourse but to sue us to get money to care for their child. They don't have a choice. And your documentation can either help or hinder that process for them. And that's not to say you're putting your hand up and saying, yes, I did this wrong. It's about being honest and truthful about what's going on at the time and writing that in the notes. From my own example, one of my daughters suffered a 4th-degree tear after her second baby, which was completely avoidable. But when we actually got the documentation, her documentation was a series of tick boxes and bore no resemblance whatsoever to what happened in the birth room. I've also had to give evidence in a coroner's inquest before now. And I only looked after the lady for an hour, but I was in the box for 2 hours giving evidence on that hour. And my documentation was such that I was able to answer every question, even though it was well over a year after the event. But I was able to answer every question that was put to me because my documentation was such that I could answer these. Now, if you haven't written full explanations of what's going on in a room, and you are called to give evidence in a legal capacity, or even just within a well, can't think of the word now. If there's been a serious incident and they're just investigating it within locally, you will sometimes be asked to give a factual account of what's happened. If your notes will help you give that factual account, assuming that you've actually written accurate records at the time, so they can help rather than hinder. It also gives a full picture of the care that's been provided to that woman. Now, this is extremely important, and particularly with the whole advent of the whole birth trauma report. In your various trusts, you may have something called like birth afterthoughts or birth reflections, debriefing services for families. I've, as I'm sure Sue has over the years, debriefed many families, and sometimes years after the event. And when you're looking at the records, tick boxes actually don't tell you what was going on. They tell you the tasks that were performed, but they don't give you the story of what was going on in that room. This is where your free text, in whatever system you are using, there's usually a capacity for you to free text things. And that gives you the ability to actually add those extra bits in. So how is she coping? What strategies have you put in place to help her cope? What is her concerns? What have you suggested to her? All of those things that you can write in that free text that gives that full picture of the care that was provided, rather than ticking the box, cup of tea given or refreshments given, car parking given, resuscitate checked. They are very task focused. They don't give you the picture of the care that was provided. And that is really crucial, I feel, when you are trying to debrief um, families after the event. And sometimes they need debriefing, even if everything's gone swimmingly well. I have in the past debriefed a lady 5 years after her. She was pregnant with her next baby and she'd come for a debrief. And I looked through her notes and I could not see anything that made me think, why was she so traumatized by this? And it turned out that, right near the end, the fetal heart had decelerated. She'd been transferred from the birth unit, delivered her baby very quickly on the delivery suite. And nobody, when I was going through all the notes with her, and I went through the CTG with her and pointed out all the bits and said, oh, and looks like your baby had the cord around her neck, and that's probably what caused that. And she said to me, I'm sorry. And nobody had spent that time just saying to her, that's probably what caused it. It's, not that uncommon. And she's had 5 years of trauma and anxiety. So it does, it's really important that you write all those things down, because if somebody hadn't written cord around the neck in the kind of story bit, we wouldn't have known that, and she still wouldn't have had any good reason, that I could find in her notes for why she was so traumatized by it all. Record keeping is really important for your multidisciplinary team working. Who's doing what? What is the plan? What is the management plan? What if they've been seen by obstetricians? What was that? What was the outcome of that? You need to be able to access those so that you can get a good picture of what is the care plan for this particular pregnancy and birth. And sadly, because of litigation, which we have already touched on, so I won't go back into that again. So types of documentation, the most common for us is our clinical records, which are either paper or electronic. You can have minutes of meetings, you can have various pro formas, you can have charts like your observation charts. For my current practice, both trusts that I work at are electronic. Some of the issues I have with electronic documentation, apart from the fact that it's very tick boxy, is that it can take your care away from the woman, particularly in labour. Now, when I had ran the birth unit, I used to and I had paper notes. I could get on the floor with my piece of paper and my pen, and I could still be with woman on the floor writing my notes, and still be very much in contact with her. That is much harder in one of the trusts I work in, because the computer is kind of on wheels, it's up in the air, and you become very, very focused with that screen and making sure you have done all your fresh care and your fresh eyes and your all of these things that you have to do while you're caring for someone in labour, that your focus can be really taken away from the person that is in your care. The other trust I work at have iPads. So yes, you can get back on the floor. But the problem I find with the iPads is I have nice big fat arthritic fingers. And so it's quite difficult to type on an iPad, free text. And plus the actual platform they use, I find quite challenging as well. I'm sure I'll get used to it eventually. But that makes it a challenge, even though I can be closer to the woman when I'm doing it. Your focus is still very much on that computerized screen. So the systems, I was saying, computerized. So Bajonet, K2, Epic. I'm sure there are others across the country. They are not the same. I mean, ideally, it would be lovely to have exactly the same system throughout the whole of maternity services. That you'd kind of think would be sensible, because we'd all then at least be singing from the same song sheet and we'd be filling the same things in. It would make it less traumatic for people, particularly when you're going from trust to trust. As I say, I work with a K2 in one trust and Bajonet in another, and I find they're both completely different systems, and both of them have pluses and minuses to using them. And obviously paper. Big fan of paper, but that's probably my age. So things to consider as well. Women have access to their notes. So you need to think about what you're writing. Gone are the days when, and Sue will remember this, when you used to write things like FLK, funny looking kid. You have to write you have to be correct. You can't write things like that. And I mean, you shouldn't have been writing them anyway, but certainly it definitely happened. They definitely used to get written odd things in people's notes. You need to be mindful if you've got safeguarding issues that you're using confidential modes when you're writing things in notes, because again, if you have perhaps domestic abuse, the partner may be accessing those notes. So you need to be mindful about what you write and what there's access to for things like that. If you're transferring to another ward or unit, they don't have the same system as you. So do you need to think about printing off your records so that the woman can take hard copies of anything with her? Even interdepartmental access is a challenge. Because K2, certainly at one trust, is within the maternity department, but it doesn't exist outside the maternity department. So if she was going to be seen in A&E, they wouldn't necessarily have access to anything that's gone on before. If she was on a medical ward, they wouldn't have access to anything. Our GPs and health visitors don't have access to a lot of those computerized systems. Think about your students as well. It's really important that you, as midwives, are actually teaching the students how to document. That it's important. I mean, I actually had a lovely comment from a midwife who's been qualified quite a few years now, and she was one of my students. Our systems actually in one of the trusts completely crashed for a weekend. And the amount of people that suddenly said, I've forgotten how to write. I've forgotten what to write, because they have become so used to ticking boxes and using wizards to complete checks and all sorts of things that they'd forgotten how to write. And this midwife said to me, I can still remember how to write a vaginal examination up, Lynn, though, because you taught me, which I found was quite amusing. Don't forget as well, if your students are documenting, that you have a duty to countersign their documentation. And some systems, like the K2 system, within the labour area, there is a button on there that you can, a mentorship button that you can tick and put your fingerprint on, so that will countersign. But outside of that, so the antenatal and postnatal bits doesn't have that facility. So I have to go in and free text and say all documentation by student read and agreed, and then sign it. Otherwise, I haven't actually countersigned her documentation, whereas if it was paper, I would be countersigning it. So just because it's electronic, just remember that you still have that duty. You are ultimately still responsible for that woman's care, even if your student is providing the care and the documentation. You, as the midwife, you're the one with the pin, you're the one with the registration. So you do need to be very careful that you countersign everything that they have written. So thinking about the different periods and some strategies that you can look at. So over the last sort of couple of years, I've been quite heavily involved with preparing the international midwives for their NMC OSCEs. And part of their OSCE is they have what's called an API station, which takes the best part of an hour. And they have an assessment station, a planning station, an administration station, so an implementation station, which is essentially a drug administration station, and then a evaluation station. So this kind of very much looks at using an SBAR, situation, background, assessment and recommendation framework to do an assessment on someone. And they could get any sort of scenario. It could be antenatal, it could be intrapartum, it could be postnatal. So the framework is exactly the same. But so although I put booking here, the little analogy we use, acronym we used, to try and get history out of someone and that background was so mad. And because sometimes you get so mad, you've just got not enough time to do anything, and it kind of it stuck with them. So when even if you've got someone coming in labour, you've got someone you're seeing in a triage area, what is their social history? Have they got a partner? How are they living with somebody? Are they supported? Do they smoke? Do they have any of those? Do they take illicit drugs? Is there anything in that social history, children's social care involvement, any of those things that might be an issue? And O is for obstetric. Okay, so what's this past obstetric history? What's this current obstetric history? Are there any specific problems in this pregnancy that you need to know about? What's her medical background? Has she got any underlying conditions that you need to know about? Has she got any allergies? And is she on any drugs? Is she on any medications? So if you kind of think about SOMAD, in a very short period of time, you can elicit quite a lot of information that you can put into your sort of situation and background boxes of your SBAR handover. Management plans are another thing to look at and put. So very often when I do a booking, you start a management plan. So what is the plan at that point in time in booking? Is she a low risk pregnancy, in which case you're writing down basically some of the SOMAD details, the salient highlights in that management plan, and what's your plan going forward? If she's a higher risk pregnancy, what's your plan going forward? If she's been seen by obstetricians, look at the management plans that have been put in place, because they will guide you as well as to where you need to go. Is there safeguarding issues? Have you addressed that? Risk assessments, we are very, very risk averse now in the NHS, and I'm sure that all of your systems, whichever you use, are equally as lengthy as K2 in the risk assessments, because you've got risk assessments for VTE and fetal growth restriction and PPH and there's a gazillion risk assessments that we're doing. We're not, as I say, we do these risk assessments and we don't always think when we're doing them, have we given that woman informed choice about where these things might go? And I think specifically of things like VTE. And I'm a huge fan of Sarah Wickham. If you have not read Dr. Sarah Wickham's books, I totally recommend them all. Her latest one, Plus Size Pregnancy, very much looks at BMI, and it's a big eye opener when you read it as well. But she's already done all the hard work for you. She's looked at the research around VTEs and all of these things. And she actually, in one of her blogs, had said about informed choice, and she'd said, do we actually tell women when we do a urine sample on them, if we send it off, that if it comes back with GBS, that's going to very much curtail her pathway in labour? And I have to say, I hold my hand up. I never did. I take the urine, I dip it, and I say, yeah, we'll send it off, make sure there's no infection in there. But I hadn't followed that up with, if this was to come back with this, it may have implications on your pregnancy journey. Never even gave a thought. And I thought, so am I really giving this woman informed consent, choice? And I thought, no, I'm not really, because she could quite happily say, no, I need to decline that. So I'm aware time is marching on. So intrapartum, some of the things we're obviously documenting, it's important you're documenting your observations, both maternal and fetal. Don't just document them though. If you're on an electronic system, it very often will have a meows chart there, but unless you look at the meows chart in its entirety, you cannot see a trend. You will just see that set of observations is kind of normal. That set of observations is normal. But when you look at the meows chart, you might see a rise in something, and likewise with the partogram. If you don't look at it in its entirety, you will not get that sort of developing trend that's going on. So please do look at those. And again, the story, the free text, write in what's going on, what's been happening. Postnatal, again, have that holistic top-to-toe approach. If you always start at the head and work your way down, whether you're antenatal, postnatal, intrapartum, you are not going to miss anything out. Put your plans in place. Think about the baby. What does the baby need? Are there any specific um, things you need to think about? Your documentation around the baby, feeding advice, feeding support. And so, very quickly, as I know that time is marching on, so make sure you know your notes are as contemporaneous as they can be, um, that they are accurate, that you date and time them, that you sign them, you countersign your students, and if they are paper records, that they are legible. Electronic, I have to say, I become very dyslexic when I'm typing, and some of my spelling is atrocious when I look at it. And I'm afraid on some of them, I'm pretty much shouting at everybody because everything's in capitals because I can't do this swapping from lowercase to uppercase. So it's either all one thing or all the other. So thank you. I hope that I could go on for hours, but I won't. So thank you all very much.